When you are going in to conduct your assessment of your patient with a chest tube, the first thing you want to do is check the doctor's orders. They will either state to put the chest tube to suction, to water seal, or to clamp it. Note as well how much suction the surgeon would like the atrium to be set at. When you go in the room, you can start by assessing the atrium. Typically, our patients are at -20 suction, as it reflects here. You know that your suction is hooked up appropriately if this orange bevel is out, as I showed you in the previous video. If the orange bevel is not out, troubleshoot like we went over before, and make sure that the wall suction is high enough so that this can come out appropriately. A few other areas you're going to want to assess on the atrium itself is down here. This is where we will look for air leak and titling. An air leak is a bubble that will travel completely from one side of this area to the other. It's a continuous air leak if that's happening continuously. You may also want to instruct the patient to either talk or cough or move around a little bit, which can stimulate an air leak as well, and we consider that an intermittent air leak if it's based off of what the patient is doing. Various patients may develop air leaks if the air leak is new, as in they haven't noted it on the last shift or for the last few days. Make sure that you're telling the surgeon because that is a significant change that they need to be made aware of. Another thing you may note here is if it's titling. That will be when this white ball in this column moves up and down based off of the patient's breathing pattern. That's nothing to be alarmed about, but it should be noted in the charting. You also want to note the type of drainage that's coming out from the chest tube. Depending on what the chest tube is there for, the drainage may look different, but if you do know a significant change in the drainage, whether it be the color or the amount that you're getting, ensure that you let the surgeon know that as well. Now we want to make sure that the chest tube coming out of the patient is correct as well. You'll want to milk the chest tube with every patient interaction, but at minimum every 2 hours. And that just means draining everything that's in the line directly into the atrium. This also gives you a good opportunity to check and make sure that the tubing isn't kinked. A kink in the chest tube may cause the lung to collapse more than it already is, so we want to make sure that we're assessing that with every patient interaction as well. In regards to the dressing change, they will have one of two dressings on them, a percustay or just a regular drain sponge. And there will be orders to apply bacitracin for the dressing changes as well. So what you'll do is put a really thick amount of bacitracin around the chest tube insertion site itself. This helps create an extra barrier to make sure the air doesn't get in and out. So apply liberally, directly from the tube usually. And then the drain sponge will just fit around it and you'll secure it appropriately. You also want to make sure that you're assessing for crepitus at this time. Crepitus is air that leaks out into the subcutaneous tissue, and it feels like Rice Krispies popping around the patient's skin. The air will move upwards. It's not necessarily anything to be alarmed about, but it should be noted. And if the crepitus moves all the way up to the neck, it may impair the patient's ability to breathe, and it may also lead to vocal changes. If you're noticing a great increase in crepitus, or it is affecting the patient, please make sure that the surgeon is aware of that as well. If your atrium becomes full at any point, we can replace it. The most important thing to make sure you do when you're replacing an atrium is clamp the chest tube. If the chest tube is not clamped when you change it over, you risk a pneumothorax for the patient. So obtain your new atrium and clamp the chest tube with the blue clamp here. And this port here will just come off and you'll apply the new atrium like this. You'll do your safety checks as we talked about previously, making sure that the suction is set up correctly and all of that. Now, If you want to take your chest tube patient for a walk, you need specific orders that state the patient is okay to ambulate on water seal. If they're not, you will get a portable suction machine, but I'll show you first what water seal looks like. All that means is that you take the suction tubing off of the chest tube itself, and now the patient is free to move about as they please. If you do need to apply portable suction while they're ambulating, that looks like this. And you plug in the suction tubing as you would plugging it into wall suction. You can see there when the suction is turned on that the bevel comes out, and you know that that is hooked up appropriately there. And once they are back in the room, you can hook them back up to wall suction, ensuring, of course, that the bevel comes out appropriately. One more task you may ask to be performed is the flushing of the chest tube. If there are orders to flush the chest tube, there will likely be a four-way stopcock that looks like this. This end going to the patient, this end going to the atrium. And what you will do is clean this port like you would an IV port, and you can hook up a normal saline syringe to this end of it. Always make sure you're flushing towards the patient. So for that to happen, just turn this bevel so that it is blocking the going to the atrium. And you'll flush it in, and then just make sure that you turn this bevel out to allow it to flow back out afterwards. We do that to ensure that the tube doesn't get any clots in it and that we're getting adequate drainage coming out of it. And that is how you assess a patient with a chest tube.